So my topic right now is pancreatic cancer imaging and what the surgeon wants to know and what the radiologist should know actually, a little bit more than we usually see. And stuck. Okay, so my lecture is going to go something like this. I'm just going to give you a short introduction and I'll tell you how to stage pancreatic carcinoma. Then I'll give you how you take a decision regarding resectability, which is what all surgeons get a scan done for. And I'll tell you some other things that the surgeon needs to know, which we can tell them and which can help both the surgeon as well as the patient. Okay, so what are the imaging modalities for pancreatic carcinoma? And I'm not going into neuroendocrine and cystic tumors. I'm telling you what to do when you get a pancreatic carcinoma and the surgeon is asking you, is this resectable? Should I open the patient or not? Okay. So, multidirector CT angiography, MRI with MRI angiography, PET CT and endoscopic ultrasonography. These are the main modalities you have for imaging of pancreatic carcinoma. Now, whatever anybody says, I feel CT is the mainstay. That is what literature also says, although a lot of people are now using MR. The problem with MR is it has a slightly lower spatial resolution, it has longer breath holds, long exam times. Although you can use it for problem solving tools when you have an isodense mass lesion or you feel you have a liver lesion which you cannot characterize adequately with CT, so you go ahead and do an MR, right? EOS is generally done along with CT and MR, never alone, because it doesn't tell you about distance spread at all. And as far as I have seen, I feel that a good MD-CT is as good as or better than EOS. I think it is better actually than EOS as far as involvement of the vascular pedicles go, whatever the EOS guys say. PET CT should not be done without the CT component, and PET actually adds a lot of unnecessary expense. So unless it's a big lesion, I don't see any role of adding the expense of PET. So and what is the importance of staging or imaging rather? So only 15 to 20% of newly diagnosed patients have resectable disease at the time of presentation. Fine. If you do an R1 resection, which is a microscopic, or an R2 resection, which is a macroscopic residual tumor, these patients have the same survival as a patient who hasn't undergone surgery. So basically you are going to make the patient miserable, make him spend a lot of money, and then you are going to give him no survival benefit. So when you are selecting your patients for a Whipple's, the role of the radiologist is really major, and I cannot stress that enough. So the staging from the AJCC perspective is that you assess the primary tumor, the nodes and the metastases. So T1 is less than 2 centimeters surrounded by pancreas, T2 is more than 2 centimeters surrounded by pancreas, T3 extends beyond the pancreas but does not involve the celiac trunk or SMA, and T4 involves the celiac or superior mesenteric arteries. Now I want you to pay great attention to this diagram. I think it's very pretty because I drew it myself. So anyway, so this is the T1, less than 2 centimeters surrounded by pancreas. That's what you mean by T2, which is more than 2 centimeters, but it is also surrounded by pancreas, which means that the scope for peripancreatic invasion is very less. T3 is going out of the pancreas, and T4 is going and involving, as you can see over here, the superior mesenteric artery. Fine. So this is your T staging. N1 is enlarged lymph nodes, N0 is none. M1 is distant metastasis and M0 is none. So that is the AJCC. So lymph nodes are named according to lots of things, but I'll tell you the practical aspect of lymph nodes. The practical aspect says that if you have a lymph node which is going to be in the area where the surgeon is going to resect, it really doesn't matter. So even if it is a small lymph node, they'll take it out. If it is a large, definitely you can tell them, but if it is in their scope of resection, they're going to take out the lymph node anyway. The problem with lymph nodes comes when they are going to be outside the surgeon's field of resection. That means to the left of the SMA. They will generally not go too much to the left of the SMA. If it is not too far and you tell them, yes, I feel there is a single node that I can see, to the left of the SMA, he may make an effort. But lots of people will not include any lymph node to the left of the SMA as a Loco Regional lymph node, which they will take out, right? That's a big lymph node again. Necrotic, definitely involved. Okay, and this is lymph node, again to the left of the SMA and the mesentery. These patients definitely should not undergo surgery. They are not going to get a R0 resection in any case. So how do you stage? So stage 1 is a T1 or T2 tumor, stage 2A is a T3 tumor, stage 2B is a T1 to T3 with lymph nodes, stage 3 is a T4 tumor, and any tumor with a metastasis is a stage 4. Okay. Now comes the resectability. Now the National Comprehensive Cancer Network, which is a group of hospitals in the USA, has simplified this to a great extent, in the sense that they have classified these tumors into 3 categories. One is a clearly resectable tumor, one is a clearly unresectable tumor. So with both of these there is no issue. The radiologist is happy, the surgeon is happy, we both know what we have done. And the problem comes with this. When you say this tumor is borderline resectable, which basically means I am telling you this is there, this is what I find, go ahead and take your chances. So these borderline resectable patients are the ones which require a lot of expertise on the part of the radiologist and on the part of the surgeon, and I will just show you why. So this is how you basically group these patients. These are the NCCN criteria. I'll just show them to you. So before I go any further, there is this concept of abutment versus encasement, and lots of people have managed to get out lots of papers and no doubt lots of funding on whether this is abutting or whether there is encasement. So apparently the consensus is that if you have less than 180 degrees involvement, you can say that there is abutment, and if you have more than 180 degrees involvement, you can say there is encasement, particularly arterial. As far as veins go, if there is distortion of the vein, or you can see obvious tumor in vein, then you can say that this vein is going to be involved. If it just abuts the vein with less than 180 degrees and no distortion, the vein is less likely to be involved. And this is what I could get out of all the papers that I read on this subject. So that you see that vein being pulled medially, that vein losing its nice shape, being pulled like this, like a beak, that means that this vein is involved. Okay, so this is just a snapshot of the NCCN guidelines for pancreatic adenocarcinoma. This is available free off the net, and you should actually take a look at them. NCCN has good guidelines for a lot of imaging for a lot of malignant lesions, and I look at them a lot. So at any rate, the clearly resectable tumors have no distant metastasis. That's a no-brainer. There is no overt adenopathy. That's fine. There is no evidence of tumor contact with SMA, hepatic artery, celiac trunk, portal vein, or SMV. That's a resectable tumor, which basically means it is a tumor inside the pancreas, not touching anything. You can't see a lymph node, you can't see a metastasis, you can't see any mental deposit, you can't see anything except a small tumor sitting inside the head of the pancreas. That is a clearly resectable tumor. So there is no fight in that. Then come the tumors which are clearly unresectable. Distant metastasis, very good. You know that. More than 180 degree SMA encasement. Any celiac abutment, IVC involvement is clearly unresectable. Unreconstructible superior mesenteric vein or portal occlusion, and I will tell you what unreconstructible means in a while. Aortic invasion and lymph nodes beyond the surgical field, which I just showed you a little while back. So all these are clearly unresectable. And now comes the problem, and that's a clearly unresectable tumor according to the NCCN criteria. That's the celiac trunk, everything is surrounded. Okay, and now we come to borderline resectable. No distant metastasis, so theek hai, understood. Venous involvement with suitable vessel proximal and distal for replacement, which is a very wide statement. Short segment encasement of the hepatic artery without involvement of the celiac axis, that we can understand. And tumor abutment of SMA not to exceed 180 degrees. So less than 180 degrees for SMA, short segment encasement of the hepatic artery, and venous involvement with suitable vessel. Now, venous involvement is a very iffy topic, and I'll try and explain it to you if I can. So when you see all this and you do all this imaging and you see that I have this much of venous involvement or this much of arterial involvement and no lymph nodes and such, 15 to 20% of patients are operable at the time of surgery, and this includes patients who are going to get in a venous interposition, an arterial interposition, and maybe after neoadjuvant chemotherapy, which is something I have not dealt with in this lecture because it's too exhaustive. But so what do you mean by venous resection and reconstruction? So the earliest papers which I read said that you should have no more than 15 mm of length of contact with the portal vein to call it resectable. Okay, so basically I'll explain that to you just now. So to allow removal of tumor involving SMV, portal vein or splenoportal confluence, you can do vein patches, you can do interposition grafts, you can do primary anastomosis. Primary anastomosis now has gone up to less than 2 cm, the length of involvement. It is not possible to anastomose multiple lumens, which means what? You know the SMV is formed by multiple branches, and the main ones that come where the cancer is going to be involved is the gastrocolic trunk and the first jejunal vein. The gastrocolic trunk will come from the right and the first jejunal vein will come from the left. So if these two are involved and you are trying to save them, then you cannot remove the portal vein and then anastomose the gastrocolic trunk and the first jejunal vein. So you can't anastomose multiple lumens. Okay, so these are your venous reconstruction options, and now I'll tell you what I meant. So what you can do is, when you have a tumor, if you have a tumor which is less than 2 cm now and which started off at one point of time when I was reading either here or here as less than 1.5 cm, you can just remove the tumor along with the vein and do a primary anastomosis. If you have a tumor which is not satisfying this criteria, you can put in a graft. What you can do is remove the vein with the tumor and try and put in a graft, right? And this is what I meant by a short segment involvement of portal vein. What you can do is just take this out. Some people put a patch and some people just suture it and narrow the portal vein, and only the radiologist knows. Our patient obviously doesn't. So now a tumor abutting the SMV. So is this clearly resectable? It is not clearly resectable because there is abutment of the superior mesenteric vein, and that is not in the clearly resectable criteria. Is it clearly unresectable? No. So now this is a borderline resectable tumor. Now borderline resectable depends a lot on your surgeon as well. If he is confident doing vein patches and vein grafts, it is borderline resectable. If you go to Junjunu, then it is clearly unresectable. So it depends on a lot on the expertise of your surgeon and how much experience he's had putting in vein grafts. And that is what he's going to do. He's going to remove a portion of the vein and he's going to put in a graft there. Now tumor infiltrating the SMV. This scan was sent by a friend of mine as a joke a long time back, but I'm still using it for my talk. So you can see the tumor is actually almost invading into the superior mesenteric vein, and that is the first jejunal vein. The one which comes from the left behind the SMA, that is the first jejunal vein. So when I was having a talk with my surgical colleagues about the gastrocolic trunk and the first jejunal vein, I said all the Western literature says that you have to preserve either at least one of the two. So he said, no, we tie off both, nothing happens. So actually speaking, the literature says that you have to preserve one, but the surgeon says he doesn't care. So at any rate, if there is just this much involvement, we tell our surgeons that this is what I can see, and the first jejunal vein or the gastrocolic trunk is involved. Do you want to still go ahead? And then they take their own call. But it is always good to tell them that it is involving the gastrocolic trunk or the first jejunal vein. So the next thing that we do, we've done the venous reconstructions. Now we go to hepatic artery reconstructions. So GD involvement is not a problem. Why? GD is going to come off with the tumor. Short segment CHA involvement, you do a primary reconstruction. And a longer segment CHA, you put a vascular graft. Okay. So short segment, primary anastomosis. Longer, you put a graft. So before I go any further, I'll just show you one slide on the peripancreatic neural plexus. These images are not as pretty as the ones I had drawn, but I'll still try to show them to you. So there are two main plexuses. One is a plexus 1 and plexus 2, or pax 1, pax 2, depending on which what you are reading. So one goes through the GDA to the CHA, to the celiac axis and to the celiac ganglion, and the other goes from the uncinate process from the posterior inferior pancreatic duodenal artery along the SMA to the ganglion around the superior mesenteric artery. Okay, that's the article if you want to read it. So once the tissue goes along the peripancreatic neural plexus, you may not see the primary tumor extending as such to the artery, but you can see this. Can you see this ill-defined soft tissue thickening around the SMA? Again, I showed you fat last time. This is fat. Fat is black, and this is gray. So this is gray. So this gray stuff is all tumor, which has come from the peripancreatic neural plexus to surround the superior mesenteric artery, and this is also unresectable. So even though the primary, you cannot even see the primary tumor in this area, right? Because the primary tumor is going to be lower down, probably near the uncinate process, but you can see this soft tissue around the SMA. So this is all coming from the peripancreatic neural plexus, and that is the posterior inferior pancreatic duodenal artery coming here and tumor surrounding the SMA. Now I'll tell you why I told you this. Okay, now look at this patient. Is the SMA free? That's the SMA. That's the SMA. Is it free? No, it is not free. What is happening is there is tumor extending in from the peripancreatic neural plexus and abutting the SMA here. So there is short segment involvement of the SMA, right? So now I'll tell you what is the implication of this. Median survival post surgery for any patient after Whipple's is 11 to 20 months. After you do all this and you do grafts and you do all that, it's 11 to 20 months. Local recurrence is going to be 60%. Okay, now there is a difference between the arterial and the venous involvement. With venous involvement, the survival is the same as that if you took out the whole tumor and you put in a graft. Because the arteries have a periarterial neural plexus, if you do an arterial removal and reconstruction, the results are not that good, generally because of the involvement of the periarterial neural plexus. So most people will go in for a vein graft very easily, but will not like to do an arterial reconstruction because it really doesn't help the tumor. Okay, now for some fun cases, the last part of my talk, what else the surgeon wants to know. So this is a resectable pancreatic carcinoma. It is resectable, I am telling you it's resectable. The SMA is free, the SMV is free. Okay, but what is interesting in this patient? Can anybody tell me what this is? I have written it there. Okay, so what happens, what is the implication of this? The implication is, when you don't report this and the surgeon merrily goes and ties up the GDA, the hepatic artery pulsation stop. Why? Because there is no flow from the celiac. All the flow is going from the SMA through the GDA and into the celiac and the celiac branches, okay, including the hepatic artery. And we have had this, we have had the patient open on table and one of the surgeons running down and saying, I tied up the GDA and the patient's liver stop the patient's hepatic artery stop pulsating, what's the matter? So now we have learned that if you have a predominant collateral pathway which is going through the SMA and using the GDA, because the GDA is going to be tied off during Whipple's, you have to tell the surgeon that take care of this part of your blood flow. So they will probably do a celiac artery release. That is one. Another patient. So this is again another resectable tumor. SMA is free, SMV is free. Some artery here, maybe, I don't know. Let's see. There is a vessel. That's a tumor. So what's happening? Look at the angio. Now this patient has two separate right hepatic arteries, and one is arising almost from the GDA. This is a matter of nomenclature, what you call it, RHA arising from the GDA or the GDA arising later after giving off the RHA. But the moral of the story is that tumor is extending till here, and if the surgeon goes up to try and clear off the GDA, he may go and tie off the RHA. You have to tell him again that your RHA is arising almost from the lower part of the GDA. So that's another thing. There, that's going to be his, where he ties off the GDA. Okay, now this was a small tumor, it was totally resectable, everybody was happy until we saw this. What is this? Looks like a vessel. Where is it? It's inside the head of the, you can actually see the head of the pancreas. That's the head of the pancreas, right? You can see a vessel inside it. Okay, so now what happened to this patient was that the celiac trunk divided into the splenic and the left gastric artery. The common hepatic artery was totally replaced to the superior mesenteric artery, and because it had no other place to travel, it travelled through the head of the pancreas, and the head of the pancreas is removed during Whipple's. So you cannot remove the common hepatic artery. So we had to tell the surgeons this, and the surgeons kind of shelled this off but this patient developed a leak from the pancreatic jejunostomy, and because this artery was totally skeletonized, rapidly developed a pseudoaneurysm. But this was, if you had not told the surgeon this, and he had gone and removed the head of the pancreas, the pulsations in the liver would have stopped immediately. So you would have ended up killing the patient of other causes. So the role of the radiologist is really important, and I cannot stress that enough. Okay, sometimes you have a problem with isodense masses. So up to 10% of the tumors will be isodense on CT, even when you do a good CT, and that is what literature says. Fine, now you can see that the CBD stops here, the pancreatic duct stops here, right? So there should be a tumor here. Obviously, otherwise why would these two things be obstructed? But you go down also, you cannot see the tumor. What you can see though are secondary signs of the tumor. And you can see that there is some lymphadenopathy, some soft tissue, and some wasting. Wasting means a waste. Wasting of the portal vein here, which suggests significant portal vein involvement. So although I couldn't see the tumor, I could see the ancillary signs of the tumor and significant portal vein involvement, with likely secondary to this soft tissue which was secondary to tumor. MRI will help you to delineate the exact size of this tumor. Although in this case there was not much aim, but you can do an MRI in these patients where you are sure there is a tumor but you can't see it. Okay. Alright, this patient, resectable, that's the SMA, that is the portal vein. Resectable? Nobody is taking a call? Okay, resectable. Fine. Okay, we'll go to resectable. Now what do you see? That's a replaced right hepatic artery arising from the superior mesenteric artery, right? And that's your tumor. And this artery is going very, very close to the tumor. So that was a MIP. Let's take a closer look on your source images. What do you see? Artery surrounded by this tumor. So it is not only the SMA and SMV that you have to look at when you report a pancreatic carcinoma, right? So this appears to be involved. So we told our surgeon, this might be involved. Oh, he'll take it out. So, okay. So, what happened? Patient was operated. What do you see? There is no RHA, okay. They tied off the RHA because it was involved obviously. And this part of the RHA, you can see the LHA but you can't see the RHA. This part of the RHA is filling through collaterals. And what is this? That's an infarct in the right lobe of the liver because the surgeon tied off the RHA during a Whipple's. So these things happen. Okay. Now this is a clearly unresectable carcinoma, okay, according to NCCN criteria. There is no doubt about it. Celiac trunk, right, left, everything involved. Okay. You sure it's resectable? Unresectable, right? Okay. Everything is around it. Sure unresectable? Or somebody says it's resectable? No votes for resectable? Okay. So is it really unresectable? So there is something called a modified Appleby procedure where you can take off the entire celiac trunk. Fine. And that is what the surgeon did. He took off the entire celiac trunk with the body of the distal pancreas and tried to put in a venous an arterial interposition graft, which is this. Can you see this faint hyperdensity? I am not sure you can. Can you see it? This was the graft. The graft got thrombosed. This was a collection around it. But the patient is doing well. Why? Because the GDA decided to help out. So just a case, which is just an interesting case where you removed the entire celiac axis, but you can still see the hepatic arteries filling through the GDA, right? Oh, okay, there, that's the VR image for this patient showing you that he actually has no common hepatic artery and no celiac trunk actually, and those are the surgical staples. So that was an interesting case we had. Liver lesions, if you have so many and you have a patient who has fever, try and characterize them further. There may be cholangular abscesses. Coming to chronic pancreatitis with mass, most of the time I can't tell the patient has a tumor until there is an obvious tumor which everyone can tell. And one of the things where you can tell is that this fat plane around the SMA, right, is not supposed to be involved in pancreatitis. So this fat plane around in inflammatory changes is generally preserved. And in malignant changes it is generally involved. And this is what kind of spread? This is all perineural, correct. So tumor was a little far away and all the tumor came along the perineural region. That's great. One more thing is, if you have a surgeon and who does talk to you, you can tell him that get a scan done before you stent the patient. Why? Because they cause pancreatitis many times, and they smudge up all the fat, and that's not very good as far as the accuracy of diagnosis goes, right? So try and keep the procedures for after the imaging. This was a pancreatic body tumor. Pancreatic body tumors also have NCCN criteria, more or less the same, and as far as perineural spread goes, they do involve the splenic ganglion. There are 5 major ganglia, and you can look it up in the article which I just showed you. So that's the tumor. What's that? So there is a huge tumor, eroded the splenic artery, abutted and involved the stomach and got into the colon, and this patient had a GI bleed. He came to us with a GI bleed, and then we found a tumor with a pseudoaneurysm. That's a pretty picture. Okay, another patient with an unresectable pancreatic mass, known to a colleague of mine, came from outside as an unresectable pancreatic cancer. And what is it? It's an autoimmune pancreatitis. You see the narrowing of the vessels does occur with autoimmune pancreatitis, and you see very nice peripancreatic halo of hypodensity around the pancreas. And lastly, there is a structured reporting template available in case you are not doing a lot of these and you want to go systematically, or you are doing a lot of these and you want to be more systematic in how you report your scans. These templates are all available on the net, and this is one I've downloaded for you, and you can kind of go and talk about the pancreatic mass, location, size, characterization, enhancement, connection with PD, accessory PD, calcification, etc., etc. Thank you very much for your attention.